Hello, Assalamu alaikum. I would like to start by thanking Sayyid Nasser, who has organized this International Psychiatric Conference 2021 in Lahore. He and his team, I'm really grateful for giving me an opportunity to come and speak with you in this conference. We are in strange times, and ideally, it should have been much better if I or other speakers were present in person. Nevertheless, I think this is a good opportunity that I'm able to record this presentation. And I'm hoping that on the day of conference, I might be able to join you virtually, where you don't have to listen to this recording and I might be able to speak to you directly. My name is Shahid Quraishi. I'm a consultant psychiatrist in rehabilitation psychiatry and low secure unit at Pennine Care NHS Foundation Trust. My task today is to talk to you today about pathways of care for first episode of psychosis in mental health services in the United Kingdom. And I will be sharing my personal experience as a clinician who has had an opportunity to treat people during their first episode of psychosis. I'm also thankful to all the delegates who have come today to attend this meeting. And unfortunately, we can be as interactive as we can, and you cannot ask me a question and that I can directly answer you. But in the end, I will be sharing my email address with you. And if you have any specific questions, you can ask me. I also make it clear to you, this is not an academic presentation. This is a very practical presentation about how the services are delivered here in the United Kingdom and what has been my experience in delivering those services. I would be talking about psychosis, but as I have already said that this is not an academic uh, presentation. I'm sure you will be hearing much more from other colleagues who might be talking on scientific papers on psychosis, or first presentation of psychosis, or first episode of psychosis. I will briefly discuss NHS. I'll briefly discuss what NICE recommendations are for treating first episode of psychosis. NICE stands for National Institute of Clinical Excellence. And as I said, that I'll be sharing my personal experience as a clinician who has been involved in treating and managing patients with psychosis during their first episode. And ideally, you should have had an opportunity to ask me questions or interrupt me, but this time it may not be possible unless I get an opportunity to talk to you virtually on the day of meeting. As I said, that this is not an academic presentation, I'm repeating. So I have chosen a slightly different stance on psychosis. As you know, that's a term used to describe difficulties in person's life. And this may include the conditions that we know: schizophrenia, bipolar affective disorders, other affective or mixed psychosis, organic psychosis, including drug-induced or psychosis following a result of drinking alcohol in excess, or feeling paranoid or delusional, and etc., etc. I mean, we are interested in psychosis, which presents with behavioral changes and behavioral challenges. And these challenges are of intensity and frequency and duration that threatens not only the quality of patient's own life, but also threatens the life of other people around him or her, and makes their life much more restrictive and exclude them from the society that necessitate them to seek a medical intervention. And this is how it is defined by Royal College of Psychiatrists. Royal College of Psychiatrists, the British Psychological Society of Royal Colleges, speech and language therapist in 2007. Why it is important to treat first episode of psychosis? Obviously, I have touched upon briefly when they present with psychosis and behavioral challenges which require them to be managed. Not only that, but again, when we talk about first episode of psychosis, it usually, not exclusively, but usually happens in young people, adolescents turning into adult life. And this is the time that brings a lot of challenges in their life. They are going through changes in their social life. Biologically, they are changing. They might be making new friends through college, through work, or when they go to university. They might be leaving homes for work or universities or education. This is the time they develop or build relationships. They learn different skills to be more independent, like driving or different skills. And it is important time for their health and well-being. So it's a transition from adolescence to adulthood. Therefore, it's a very challenging and difficult time. Again, not exclusively, but most often these patients present with not pure psychotic symptoms that we are familiar with, but they present with prodromal symptoms. And these can be very varied. The depression moods might be depressed, they might be feeling anxious, they might be irritable in their behavior, and their sleep and appetite patterns might be disturbed, and sometimes they may present confused or muddled thinking, noticing people around them are strange and unreal. So the term that we know, that derealization and depersonalization, might be experienced by some people. They might be preoccupied with particular ideas or thoughts. And sometimes maybe seeing or hearing things, but not necessarily meeting the criteria for hallucinations. They want to be aloof on their own. They may not want to be mixing with friends and family. They might be struggling at work or at school, or may not be able to achieve what they had planned to achieve. This is something we are much more familiar, and things are much easier when things are very defined. Like schizophrenia, I've chosen particularly schizophrenia because it's a core psychiatric condition with a core psychosis. And as it is described by ICD and DSM, not only with the symptoms, specific symptoms which can be positive and negative symptoms. Positive symptoms can be delusions, hallucinations, and thought disorder. Negative symptoms, as I've mentioned, they want to be aloof, might present apathy, might blunted affect, they might be withdrawn. And it is not only described by these symptoms, but the duration of the illness and how many months or weeks they have suffered from the symptoms before a specific diagnosis can be made. And this is often in the absence of prominent mood disorder. And as we know, as Schneider described in 1958, that first symptoms in the absence of organic pathology can be pathognomic, or in other words, diagnostic in making the diagnosis of schizophrenia. Now, this slide has been borrowed by Dr. Matthew Broom, who was involved in early intervention services, development of early intervention services, and for first episode of psychosis in London. And you can see that patient present with prodrome, then presents the first episode of psychosis. And first time when you try to treat patients, they recover in larger numbers. But as they relapse frequently, the remission rates and recovery rates dwindles down, and it affects their quality of life. And then we cannot treat people to their optimal level if we miss the opportunity to treat them initially or did not continue to treat them. Yeah, this is what. Now, other reasons that there are for developing the services for first episodes of psychosis. There's been a service user's dissatisfaction by not identifying earlier symptoms of psychosis and not having an appropriate treatment for those conditions, as seen in one of the surveys conducted by Etheridge et al. In 2004. And around that time, McKenzie surveyed the patients who were assessed following development of early intervention services. He was able to see the positive experience by the people who were being treated at that time compared to those who were treated in 70s or earlier years when these services did not exist. There are other study by O'Toole. He also noticed following development of early intervention services that by adhering to practice guidelines for treating patients with psychosis and early first episode psychosis, it usually gives a positive experience. NHS in England, the services are divided in primary care and secondary care. Before 2003, these were generic services, but after 2003, it was 1999 that National Service Framework came, which wanted the health services to be specific and specialized services, and these services should be available to patients' door and round the clock, means 24 hours. And post NSF, National Service Framework, or NWDW, new ways of working, the new services came into place called psychological well-being services, single point of access, crisis resolution home treatment team. CMHT actually existed, so it is not anew, it was already there, and early intervention services and assertive outreach teams, which in many places have disappeared these days, and inpatient mental health units, which also were present before new ways of working. Now, NICE, National Institute of Clinical Excellence, wants us to treat first episode of psychosis with a specific services called early intervention services in psychosis. And they reviewed their guidelines in 2014. As I was speaking earlier, I said that first episode psychosis usually happens in earlier life, but they decided to provide this service to across the board. So it's not to young people at any age. So initially there was a cutoff point that people in their mid-30s or early 30s, and anybody presenting for the first time with psychotic symptoms after 30s, they were not receiving services from first episode, early intervention services, but now they will. Now they do. And people presenting with early intervention services should be assessed without a delay. When I said NSF wanted us to provide service at the doorsteps of the patients and around the clock 24 hours, and the service cannot be provided urgently, the interventions should be provided by a crisis resolution home treatment team. And referral may be from primary or secondary care. So people who are already under secondary care services, such as well-being services, community mental health teams, if they are presenting for the first time with psychotic symptoms whilst being treated for some other condition during those services, then these patients should also be referred to early intervention services. Early intervention services should aim to provide full range of pharmacological, psychological, and social, occupational, and educational intervention for people with the psychosis, which I will cover in a minute, that how that can be achieved. Sorry, I went back. My apologies. Yeah. And considering extending the availability of early intervention in psychosis services beyond 3 years. Previously, there was a cutoff point that when people will come under these services will only be managed by the teams for 3 years. And after 3 years, they will be sent back to the generic teams like community mental health teams. NICE guidelines also recommend that antipsychotics should not be prescribed by primary care general practitioners, so they should be seen and assessed by secondary services before antipsychotics are prescribed. When they come under mental health services, the psychiatric and mental health services should offer a comprehensive assessment of risk assessment and problems with alcohol and drug and problems with any prescribed and non-prescribed medication. This should also include medical histories, and full physical examinations are offered, and looking at the comorbid physical health problems or identifying if there is any underlying organic reasons for their presentation. And when I talk about organic presentation, this can be because of the drug-induced psychosis or other psychosis related to alcohol-induced problems. Besides their mental health, physical health and well-being is also looked. It includes smoking habits, their diets, and their lifestyle, means physical exercises. Psychological and psychosocial includes social networks, relationships, and if they have experienced any trauma in their life. Looking at the developmental history, social, cognitive, and motor development, including skills like dextericities, including coexisting neurodevelopmental conditions such as ADHD and ASD. NICE also suggests to rule out post-traumatic stress disorder, monitor coexisting conditions, and develop a care plan in collaboration with patients. Any treatment that you develop or think that will be appropriate for the patient, it should be developed in conjunction with patient rather than you as a doctor prescribe it. And arrange an alternative learning opportunities where mainstream education is difficult to achieve, where there are needs for young people, they need to learn rather than missing out on their education. So alternative educational opportunities are sought. NICE also recommends that patients should be offered a medication choices, should be given information about the medication, their side effects, including extrapyramidal side effects or metabolic side effects. And they should be also given a choice whether they would prefer to have medication or psychological interventions. And mainly psychological interventions offered in psychosis are cognitive behavioral therapies. And family might need an intervention because to understand psychosis, to avoid high expressed emotions, which can further complicate their conditions. Now, my personal experience, I have been working in the NHS for a long time, but at a senior level, I have worked in CMHTs and transcultural psychiatry for 6 years, and I worked as a sector-based consultant for 5 years. And post New Ways of Working, I worked as a consultant in crisis resolution and home treatment team and assertive outreach team, half-time in both for 5 years. Later, I became full-time consultant for another 7 years in crisis resolution home treatment team. And the past 4 years, I've been providing services inpatient. So mainly as a crisis resolution home treatment team consultant and inpatient consultant. And of course, as a sector-based consultant before New Ways of Working, I have had a lot of opportunities seeing, assessing, diagnosing, and treating patients with first episode of psychosis. How we define crisis resolution home treatment team? I mean, it refers to a system for rapid response and assessment of mental health crisis in community, with possibility of offering comprehensive acute psychiatric care at home, so crisis is resolved, and usually without hospital admission. So you note some similarities that what is expected by early intervention services and crisis resolution home treatment team. It offers a rapid assessment, rapid response to see the patient in their patient's own homes. It helps patients to be managed in their own personal environment without going into hospital where possible, and offers a comprehensive psychiatric assessment, including psychosocial and biological assessment. Now, acute care is delivered by a specialist team, which involves doctors, nurses, psychologists, occupational therapists. Who can refer to the team? I put BNP, Crisis Resolution Home Treatment Team. This was my team where I previously worked. I don't work in that team. Anybody actually could refer to this team, and particularly with psychosis as well. Community mental health team, primary mental health team, they were able to refer their patients when they were acutely unwell or presenting with the first episode of psychosis. Assertive outreach team, I mean, mainly patients under assertive outreach team were psychotic. They were already established suffering from a psychotic disorder, but they were also referred to this team as well during the times of crisis. Even early intervention services, when patients were under their care, when they became unwell and they could not be managed safely by their team, they were referred. People can self-refer, or carers of family can refer them to our services. Voluntary organizations, drug teams where people were presenting with acute psychiatric presentation, such as psychosis, they would be referred to us by drug teams. A&E and UCC. UCC means Urgent Care Center. When people presented in A&E and UCC, if they were seen and assessed and found to be either psychotic at a high risk, then they would be also referred to this team. And GPs, of course, the GPs, when they see patients under their practice, GPs mean general practitioners. Inpatients also refer patients when they thought that patients were ready to be discharged, and further interventions could be achieved in community, but needing much more higher input rather than their own community mental health teams or other teams could offer, because our team worked for 24 hours, 7 days a week. After patients were referred, they were offered full psychiatric assessment within 4 hours. And after assessment, these patients will be triaged. Even if they were suffering from psychosis, but there was not a greater risk involved, then these patients will be referred to the assessment teams, or sometimes referred as SPOs, single point of access. Or if they needed to be managed in community but required much more intensive input, then home treatment team will be treating them. And if they needed much more higher input than what home treatment team can offer, the risks were higher and they could not be managed safely in community, then hospital admission will be offered. Patients will be triaged back to community mental health team who were already under their care with emerging new psychosis, with recommendations where we felt that these can be managed by their own consultants. And patients who already were under early intervention services and were referred for any risk, and if we felt that that risk can be managed by their own teams, then we refer them back to them. GPs, we will not be referring patients back to GPs unless we felt that patient did not met the threshold for requiring psychiatric follow-ups. And sometimes people who are in crisis can present as might be suffering from psychosis or other acute stress reaction, and they did not need it to be managed, then we will refer them back to the voluntary organizations or statutory organizations. And these include drug teams as well. Now, people who can access, anyone who is 16 and above, suffering from severe mental illness, this includes psychosis, of course, an acute psychiatric crisis of serious nature. This includes acute psychiatric crisis as well in first episode of psychosis that could not be managed safely. Service was not from mild anxiety disorders or primary diagnosis of alcohol or substance misuse or brain damage or other organic disorders, not necessarily suffering from psychosis. Learning difficulties were not, they were excluded. An exclusive diagnosis of personality disorder, where people had exclusive diagnosis, they suffered from a specific personality disorder, they would not be managed unless they presented with comorbid psychotic symptoms or risk or comorbid new mental health problems. And if there was a recent history of self-harm but not suffering from a psychiatric illness or severe depressive illness. Here we are referring to people who suffer from EUPD. A crisis related, solely related to relationship problems between what is happening in their own home life. Home treatment offered a full psychiatric assessment, which includes psychiatric, medical, social assessment, and required medical reviews by a psychiatrist, medication reviews with a pharmacist, regular visits by psychiatric nurses, social workers, occupational therapists, and what we call nursing assistants or support workers. Psychological support, I have already mentioned, that is been provided by the psychologist. Education, our occupational therapists will find and identify their education needs and help them. And nursing staff and other support worker will ensure that they are compliant with their treatment, because as you know, that people with psychiatric problems are often non-compliant. It's not only them, it's very well people like you and I. If we are suffering from physical health problems, perhaps we are not as compliant as we should be, or it is expected. So it is very unrealistic to expect that people who suffer from a serious mental disorder would be very much compliant. So it has already been studied and there is evidence, and I'm sure you might learn from on this topic from other speakers. And we also work with the families and carers as well, because they will need a support, and we offer them carers assessment as well. I mentioned this involve occupational therapy assessments, social support. We try to bring them back into community and include socially. We provide rehabilitation and clinical reviews when they are seen by a psychiatrist. It's not only one-off thing, but if and when it is needed, then it will be arranged accordingly. And in some cases, nursing colleagues or other colleagues will discuss patient with the consultant psychiatrist, and patients can be managed remotely. And CPS, you might not be familiar with this term, is a case of care program approach. Again, this is a term came with NSF and new ways of working. Means that when patients come under mental health services, their documentation is up to date, and documentation include risk assessment and care plans. Care plans are shared with the patients and carers are involved in the whole care program approach. There's a care coordinator appointed, who usually is a nurse or a social worker, who will be coordinating their overall care, which will be psychiatric, social, physical, psychological, or educational, and they will be linking in with other health professionals where and when appropriate. And without repeating, I mean, of course, their risk assessments are assessed on a regular basis. In summary, I mean, whether it is early intervention or crisis resolution home treatment team, or any service which aims to provide service to patients suffering from psychosis, or particularly first episode of psychosis, they should ensure that a full comprehensive psychiatric assessment is provided. It's provided by multidisciplinary professionals, like I mentioned, psychiatrist, medical doctor, who may not be a psychiatrist, means that close liaison with a general practitioner, psychiatric nurses, social workers, occupational therapists, psychologists, support workers, and education and employment organizations as well. And we need to be looking at their psychiatric, medical, and psychosocial intervention. And I must repeat here, when we are talking about first episode of psychosis and we are talking about these services, we shall ensure that these services are available. These are readily available to patients 24 hours, 7 days a week. And there is a medicine management. When patients are prescribed medication, these medication are reviewed for the side effects, and maybe our pharmacist colleagues can chip in and they can help and support, and they can, in fact, can be able to prescribe if they got a prescribing certificate. And these patients are assessed for their risk on regular basis, where there is a need for education. They should be provided because they don't miss the opportunity of left behind because of particular young people at the age when they are in the middle of education. They do not miss out. Employment, I mean, there has to be a close working between psychiatric services and employers. And our occupational therapists and support workers should help patients to get back to society by helping them to go for a shopping, go for leisurely activities, be able to travel on a bus, because if they have lost confidence, this not only includes them into the social inclusion, but also help to rehabilitate patients as well in a timely manner without developing any deficits. The main message is if we don't treat them in time, it can lead with them very serious deficit. At this point, I would like to thank you, and ideally I would have asked you for asking me questions. Unfortunately, you cannot ask me questions because it's recorded. I'm hoping that I should be able to meet you on the day when this presentation is slotted, and if it is time permitting and it is feasible, I will join you. In the meantime, you can note my email address. It's shahid.quraishi@nhs.net. If you have any specific questions about what I've just discussed, please feel free to send me an email. Thank you so much.